and welcome back to Health Watch. Been talking to Dr. Mark Oliveri about the treatment of back pain, and we've kind of gone through a lot of scenarios, but getting down to the cases that you end up seeing and really requiring surgery. And you know, it's amazing some of the new techniques, things you've learned and dislearned over the course of time, things that work and don't work. From the days that we operated on everybody with back pain, that because it was a chronic condition and it may help, to now you can be much more specific based on the diagnostic techniques that you talked about.
Sure.
So let's just talk about, you've got it, what types of cases are you talking about?
Sure.
I can help them with surgery.
And again, like we talked about, this is people who we think are okay for surgery. They've had therapy, they've had shots, they've had anti-inflammatory medication, they have a hard time working, they have a hard time functioning, and they're like, I've had enough. I can't take anymore. And then on top of that, their MRI studies have to show or MRI or CAT scan or imaging studies have to show a specific problem, something I know that if we go in and fix, we can help them. So the majority of times, and this is where we're not talking about so much leg pain, although these techniques I'm going to talk about can help both back and leg pain. For somebody who has back pain and we work them up and we find that they have a really narrow disc, painful disc, with some arthritic changes. So a narrow disc and some arthritic changes around the joints that can affect their, the pain, and they failed conservative measures, then there are surgical techniques that can help. If someone just essentially has a lot of leg pain, which we're not really talking about that, but I'm going to mention that anyways. If someone has leg pain, you can do procedures where you go in and alleviate the nerve pressure by removing some arthritic bone that's surrounding the nerve, okay? But that doesn't really alleviate a lot of back pain though. To alleviate back pain, sometimes we do have to do spinal fusion techniques to do two things, to actually do more than two things, but to help several things. Is one, if someone has a narrow disc, by having that narrow disc, it causes inflammation, and by elevating the disc up like this, it helps restore the height of the nerve opening, but also helps take that pressure off the bone. So traditionally, when we have done fusion surgeries on patients, we've gone, and I still do this, but we've gone through the back and we've utilized screws to hold the damaged segments together, and then we utilize bone on the outside of the spine and occasionally on the inside of the spine to help alleviate that pain. One of the newer techniques we have that can help prevent us from actually going through the back or even through the stomach to do the spine fusions. There's actually a technique where we can lay the patient on their side, and instead of having to go through the back or through the front, we actually develop a plane that goes through the side, and we can actually remove the damaged disc through the side and then place a cage. It's like a plastic cage that high-tech plastic cage that we fill with bone material. And by placing the cage in, we can restore the spinal height and alignment, and also help prevent that rubbing of the two vertebrae together. And that cage looks something like this. It's actually something we can directly pass through the side of the vertebra. And the advantages of doing something like this are that a posterior surgery involves usually a fairly extensive incision and a lot of muscle elevation. You can avoid that by doing this. It's actually a less invasive procedure.
You're not taking away bone.
Yeah, you're not taking away a lot of bone. I've actually done this fusion procedure on patients with an incision about this big. It's a less invasive type of procedure. And so it helps avoid that posterior. When you go posteriorly, you have to retract nerves. You have to go through a lot of muscle, and that's a little bit more of an invasive procedure. You can do the fusions from the front, but again, doing the fusions from the front involve using another surgeon, like an abdominal surgeon, to help us get to where we have to go. And it involves mobilizing organs, that kind of thing. You typically don't have to do that with this.
The lateral technique.
Yeah, the lateral technique.
So it seems kind of logical. You say, well, why weren't we doing that before? But we didn't have all the dynamics before.
Well, and the reason why we weren't is because the technology, when we go through the lateral approach, there are nerves. There's a muscle called the psoas muscle that helps you lift up your leg. And there's nerves that run through that muscle. With the technology we have now, we're actually able to identify the nerves so you can avoid them while you're doing the fusion. And that's really the key to that procedure. And again, it's one of these things I have to look for beforehand. If we actually are thinking about doing that procedure, there are some limitations to who I can do it on. Like you cannot do it on patients who have a problem at L5S1. Sometimes if the pelvis is too high, you can't do it. I have to look and see on the CAT scan or MRI if there's any sort of anatomy that would prevent
preclude you from doing that.
Procedure.
Can it be doing it at higher levels?
Yes, you can do the procedure at L4-5, L3-4, L2-3. I've gone all the way up to L1-2. You can do it up in actually in the thoracic area also. That's done with I think a more specialized guy than me.
That's a more rare.
That's very rare.
That occurs. It's funny, because that's the major stress point is the lumbar area that we all have particular problems with. You know, Mark, it's always get back to the issue, and you've certainly had experience over the years, but you really when you fuse that area, and it's always now the stresses are on the vertebral segment above. What's
correct.
What is that failure rate?
There's statistically, and that's why when we do these procedures, we look at the CAT scan and MRI to actually see if there's any degenerative changes, above. The chance of a transitional, like a patient requiring another surgery above the level of a previous surgery is probably about 5%. In their life, okay? But you do have to watch them for that.
Yeah.
Okay, and and again, this procedure I'm talking about, going through the side, it's one of these things. I've done it many times. We've done 3 or 4 levels at a time sometimes to help people who have certain types of back conditions, but it's not for everybody.
Right, that's the key. Yeah. That's great advancements. We always have pleasure hearing what new is happening with this, particularly with back pain, a very common problem. Thank you for coming.
Very good. Thank you very much.
And thank you for watching Health.